Hi folks, John Adamson, the Rehab and Documentation Guru. Welcome to Monday. Hope you're having a great day. It's starting to get hot here in Virginia, but it was still a nice weekend. And I am not bright-eyed or bushy-tailed, but I am raring to go. Today, what I'm going to do is talk to you about speech therapy documentation and documenting a little bit about skill and also about the value provided by speech therapy, because I think when I've reviewed claims for speech therapy, despite the highfalutin terminology, documenting the value of what they're doing and documenting the skill behind what they're doing can be one of the biggest challenges I've seen them face. And so I'm going to give you, mainly focusing on patients with dementia. That's the main topic I'm going to talk about here. I'm going to give you 3 things as a speech therapist to consider documenting related to dementia patients. Number 1, Medicare and other third-party payors expect that patients with dementia, which is generally going to be a progressive form of disease, are not going to make gains. And so having cognitive treatment and cognitive goals generally are going to be red flags for the dementia patient. So you have a dementia diagnosis that will potentially flag a review for dementia treatment and dementia goals, and can cause denials. So one of the things that third-party payers don't realize, apparently, is there is a body of evidence that there are a number of things that patients with dementia can rehabilitate towards with proper treatment. One particular intervention I was just looking at, which speech therapists would know this much better than I do, is just errorless practice of items has been shown to allow a patient with dementia to regain capabilities in certain aspects of their ADLs. So that is truly rehabilitation, and would show the effectiveness of what speech therapists do. But the general mindset of the third-party reviewer is going to be people with dementia or cognitive diseases don't improve, and we're going to have to possibly, especially when it comes to writing an appeal letter on some of these claims, point them to the literature that says otherwise. The other things that I would point out is that speech therapists use standardized tests oftentimes that don't necessarily convey what the true impact of daily life is on the patient. I'm not well versed enough to just bring up a standardized test and talk about its correlation to daily life, but I'm going to just use a simple assessment that a speech therapist might use, and that's looking at something like ShortTerm Recall. And speech therapists, correct me if I'm wrong on a possible application here. So you say that the patient's impaired in short-term recall, and maybe you have a way to measure that quantifiably, but I see a lot of speech therapists don't correlate that with an everyday activity. I'll give you an example where this might have some correlation. You have a patient who right now they're at home, they've got somebody staying with them because they've had some cognitive dysfunction. You're seeing them for speech. One of the reasons they can't live by themselves is that they've got short-term recall issues, and how that's manifesting to a safety issue is the fact that the patient takes their blood sugar, gets a reading, and then they forget what the reading indicates for the dosage of their insulin they're supposed to take. So that would be, and correct me if I'm wrong, but it would be a true objective clinical manifestation of short-term recall issues, that the speech therapist is not necessarily making a goal just to focus on short-term recall, but what is the actual purpose of that short-term recall being improved upon? It is to allow the patient to safely and effectively take their insulin appropriately after they get a reading. So look for ways that you can objectify just everyday life related to the measures that you're taking, and that will go a long way towards proving your value. The other thing that I see a lot of speech therapists do related to cognitive patients is their treatment. And oftentimes their treatment is what looks like rote, R-O-T-E, just repetitive training. And a lot of the denials that I have personally been involved with writing appeal letters for were on repetitive training. where the reviewer said this repetitive training could be done by a non-skilled person. And this goes along with what I've said in the past, that we have to make it clear in our documentation that every single visit is unique, that it's not just about repetitively training somebody, not rote practice. There are adjustments, there are techniques that we're going to do that's a little bit different from our previous visit that makes this a standalone visit that could not have been done by a non-licensed person. If each visit is documented in such a way that it is clear it could be just rote practice, then a speech therapist probably could have been training a non-licensed person to do that rote practice and be just as effective. But every time you see a patient, if their clinical presentation is a little bit different than the last time, and you have to make adjustments to how you approach their care that day, it's important to document what adjustments were made. And that makes it clear that it's not just a session of rote practice. Anyway, those are 3 points of speech therapists that would, to help them document value and to show skill on patients with cognitive dysfunction. If you have any other points or suggestions, feel free to comment below. Please like and subscribe. And as always, take care and God bless.